Hello everyone, this is Shad Reis and this is SIF 2021. With me is Dr. Dean Kereiakes. He is the president of Christ Hospital, Heart and Vascular Institute. Dr. Kereiakes, always pleasure to see you in person again.
Always a pleasure to be with you.
Yeah,
Thank you.
Thank you. SIF 2021 now of life, it's safe, educational. A lot of new technology introduced here. We have been a while not to be in live meeting and also live cases. Multiple cases presented about severe coronary calcification.
Yeah.
And the technology that's coming up and running now is intravascular lithotripsy.
Yeah.
Tell us about your challenge with the calcium before and how this technology evolved and how we are now.
Well, calcium's always been a problem, but it's really an increasing problem for us as interventionists because of the aging population, diabetes, chronic kidney disease, hypertension, smoking. These are all factors that contribute. And we're working on older and older people, and we're keeping people alive longer too, and so they're coming back. And calcium has never been a bigger problem than it is now. We also have a perfect storm where in our careers as interventionists, we've never had the need for big bore catheters the way we do now too, for access, whether it's EVAR, TVAR, TAVR, mechanical cardiac support. These are all big, things that back in the old days, 10 or 11 French directional coronary atherectomy cath, that was big. And the fact that we didn't have vascular closure devices at that time, it was called manual compression. These become a real issue, and TF access is #1 site, by choice with the best outcomes, et cetera. So, now we have a technology that can reliably, effectively, and safely, which is key, provide us access, and that's IVL, intravascular lithotripsy. It's different than any other technology.
Right.
For big bore vessels, it's very difficult to use atherectomy. You certainly had to do rotablator or orbital, what we use in the coronaries. And
because of the diameter of the vessel.
It's a big, 8 millimeter, 10 millimeter, but usually 8. In fact, if you look at the most common IVL balloon, is a 7 or 8, 7 by 60 is what we use most.
Right.
And so, I think this has been a quantum improvement.
Right.
FDA qualified it as a breakthrough technology. It really is a breakthrough technology.
And I think the importance, the technology coming timely because we have a very good imaging too to see how much the calcium burden is.
Yeah.
Either IVUS or OCT, pre and post.
I think that's really true. I've become an imager. I was an imager with IVUS for left main disease predominantly. And now I'm becoming much more of an imager using OCT in particular to look at the arc, the depth, thickness.
And length as well.
Yeah, and I think this is really true. The calcium volume index scoring system, we've really started to use that all the time now. We start in CAD3 and we use it all the time now.
We use this only core lab metrics, but now we see it in clinical practice as well. So you see more calcium, you have more tendency to treat.
Yeah.
So now with this disruptive technology, and because of the fear of atherectomy, do you think that will be delivering better therapy as well as delivering better stent and therapy for these patients across the country in small community non-surgical backup?
Yeah, I've used atherectomy. I was a proctor for rotational atherectomy with David Roth, the guy who invented it, and I am not afraid of it, but I think there's not adequate training coming up now. There's not enough case volume for fellows coming out. Oftentimes there's not, and it's a complementary technology. For example, if you can't cross the lesion, you're sunk. And the IVL balloon, a first generation device, is higher profile with the equipment in it that gives the emitters. It's maybe not as trackable, although 60% of our cases in CAD3 were radial.
Yeah.
Which is pretty interesting for a novel technology.
Absolutely.
And as far as the learning curve, there was no learning curve. Even a crossing, device successful crossing in the first 47 cases, the first case in all the 47 international centers, 4 countries, was the same success in crossing, the same primary safety and efficacy endpoints achieved, as the next 384 in the intention to treat population. So it's remarkable that you take this leading edge technology and you package it in a primitive delivery system.
Absolutely.
A balloon. And everybody knows how to use a balloon. It's not
bread and butter.
Yeah, bread and butter. It works.
So I have a different perspective from different people. IVL is option one is gonna take over atherectomy, or B, it's complementary to debulking device, or C, it's something just cosmetic. Which one is IVL? I know the answer, but I'm just telling you the people they ask me.
IVL is complementary in that in particularly rotational atherectomy, I use that to provide access, superficial calcium. We've all had cases that you can't get anything across.
No IVUS catheter goes, nothing.
Nothing goes. The balloon won't go.
Yeah.
So we go with a small burr. What I think that IVL adds is it is complementary. You do the superficial calcium, you get the IVL device in place, and the IVL device does the rest much more safely and effectively than anything else would do. Also, you know that complication rates go up with increased burr size, right?
Dissection or reflow.
Yeah. Also bigger guide catheter deliveries. So now you can use the smaller. You can use a 125 or 1.5 burr. You can put it through a 6 French guide. It's no big deal. And bingo, you can get across. You can put a 4.0, and you don't have to step up burrs like we used to do, step burr size upward. You can use the smallest burr possible to take care of the superficial calcium, deliver the IVL device, and then you get transmural. And it really is transmural. We demonstrated that. You'll see we're now putting together 628 cases where we have OCT, okay, and we have OCT sub-studies in CAD 1 through 4. And what you see is circumferential and longitudinal calcium fractures. And then when you put the stent, it's calcium expansion, the fracture expansion, okay, which is the mechanism of increased transmural compliance. And so I really think that the ability to do that with a 6-atmosphere balloon inflation is unbelievable. It mitigates the barotrauma that you get from high-pressure balloon inflations. With or without balloon rupture, there's much more tearing, dissection. And I can tell you that in our 628 patients between CAD 1 through CAD 4 with core lap adjudication or angiographic complications, complex dissection is a neighborhood of 2%. It's 0.3 or 0.2% with following stent deployment. It's virtually nothing. And after IVL alone, perforation, abrupt closure, and no reflow are all 0 in 628. I mean, really complicated cases.
Right. Hand-picked severe calcification, more than 270.
CAD 3 was the worst group ever enrolled in any IDE trial, and I stand by that because the average calcium arc is 293 degrees. Average, the depth, thickness of calcium, almost a millimeter, 0.96. And the calcified segment length is like 48 millimeters, on average. So this is ridiculous.
And today, Dr. Isaac illustrated that, you moderated that live case, LAD, the IVL beauty of it prevent recoiling of the vessel. And he was able to deliver a 4 millimeter stent in the 4 millimeter vessel.
Yeah,
it's
and it's phenomenal. And the result they got is incredible. And as I asked Mort Kern, I said, Mort, when you're getting 100+% stent expansion in MLAs that are, the average for CAD 3 was 6.5 millimeter MLA, and you saw this case today where they're having 8.5 millimeter MLA, doesn't that bode well long term? I call it the IVL, the gift that keeps giving, meaning the results are going to continue to be better because of optimized stent expansion. And I think that's going to be the case.
The ISR rate will be lower.
I think so.
TVL will be less. Yeah, absolutely. Yeah. Patient will come less to the hospital.
We may find late stent fractures less. We don't know, but one of the things that contribute to that is calcium nodules, calcium. So
Absolutely.
we'll see.
Well, thank you so much, Dr. Kereiakes, for your time.
Always
a
great.
pleasure talking to you about this special calcification topic with you as an expert in the field. You teach us a lot.
Thanks for the opportunity.
Sure. Please watch this video and others on SIF YouTube channel. This is Shadi Reis from SIF 2021. Thank you, Dr. Kereiakes.